Rapid sequence induction is an airway management technique where the aim is to quickly and effectively induce sedation and paralysis and insert the endotracheal tube into the trachea as quickly as possible and minimize the risk of hypoxia or patient vomiting and aspirating. It is done for patients who are at high risk for aspiration and impending airway compromise. The essential components of rapid sequence induction are preparation, pre-oxygenation, pre-medication, paralysis with induction, protection with cricoid pressure, passing the tube, that is intubation, proof of placement, and post-intubation care. The third case today is of rapid sequence induction in a 13-year-old boy for emergency laparotomy for intestinal obstruction. The airway trolley is prepared, keeping the endotracheal tube of the right size with a cylinder attached to the endotracheal tube cuff inflation system. The pre-medication, induction, and paralyzing drugs are drawn. A working suction channel is kept ready bedside, and other trained personnel to give cricoid pressure is identified. Check and secure a patent IV access, apply minimal standard monitoring, keep end-tidal CO2 calibrated and ready for use, optimize the position of the child and his head at the edge of the bed, pre-oxygenate, preferably with 100% oxygen for 3 minutes, which helps to wash out all the nitrogen and replace it with oxygen in the lungs and gives us just enough time to intubate. Pre-medicate with IV glyco, 4 micrograms per kg. IV induction agent is given, and following loss of consciousness, the assistant applies cricoid pressure. It is backward, upward, rightward pressure of about 20 newtons on the cricoid cartilage, which is a circular cartilage that compresses the esophagus below against the body of cervical vertebra and prevents regurgitation of the gastric contents. In modified rapid sequence induction, after loss of consciousness, check for confirmation of ability to bag mask ventilation by a single bag mask breath before giving the IV muscle relaxant. Now, give the IV muscle relaxant, either IV succinylcholine or IV rocuronium, as in this case. Avoid further bag mask ventilation to avoid any air into the stomach. However, you can deliver oxygen by nasal prongs by passive oxygen insufflation in patients with poor respiratory reserve. If you give IV succinylcholine, wait till the fasciculations have passed away. However, sometimes fasciculations are not seen, especially if you have given a good dose of induction agent. Also, with IV rocuronium, there are no fasciculations. After 60 seconds, the patient is optimally paralyzed. Perform the laryngoscopy and intubate the patient. Preferably, an experienced intubator should do the rapid sequence intubation and minimize the duration of laryngoscopy and intubation. Maintain the cricoid pressure all throughout the intubation. Once the endotracheal tube is placed into the trachea under direct vision, attach the ventilating circuit or the umbo bag and gently ventilate with 100% oxygen. Inflate the endotracheal tube cuff optimally till no leak is heard. Confirm the correct placement of endotracheal tube using end-tidal CO2 waveform, bilateral chest rise, and then release the cricoid pressure. Secure the endotracheal tube and confirm patient's vitals are stable. If you have used succinylcholine, then patient is likely to start making breathing attempts in 5 to 10 minutes, or if rocuronium, then in about 60 minutes. Start IV sedation using midazolam, dexmedetomidine, or fentanyl to prevent awareness in the child. Rapid sequence induction is indicated in patients at risk of aspiration as an intestinal obstruction, incompetent esophageal sphincter like in hiatus hernia, GER, patients with delayed gastric emptying, also in patients with impending airway compromise like in facial burns, fractures, shock and loss of GCS. Both succinylcholine and rocuronium have been used as a paralyzing agent in rapid sequence induction. Succinylcholine, a depolarizing muscle relaxant, has a short onset and a short duration of action of about 6 to 15 minutes, but it has a major side effect profile. Whereas rocuronium, a non-depolarizing muscle relaxant, onset of action is short with a dose of 1.2 mg per kg and duration of action around 90 minutes with this dose. Rocuronium also has fewer side effects and safer apnea time. So despite controversy, rocuronium edges over succinylcholine.